Hi, I'm Dr. Emil Liu. I'm a medical oncologist at the University of Minnesota. I'm honored to be joined here today by Dr. Petros Grivas of the Cleveland Clinic. He's a medical oncologist specializing in GU oncology. He does translational oncology, which in the era of genomic profiling is becoming very much more important. He's part of a multi-institutional collaboration between labs and the clinic, basically bench to bedside in this field. Welcome, Dr. Grivas.
Could you
tell us a little bit about what you're doing and bridging the worlds of the lab and the clinic and GU oncology?
Well, it's a very exciting time to live in the modern oncology. I think it's a specialty. It brings so close the bedside and the bench, as you very nicely and eloquently mentioned. And that's what actually attracted me to this field. I think we definitely need the laboratory in order to understand science and biology and immunology in order to make clinical decisions and translate concepts from the laboratory to the clinic. There are multiple tangible examples of that work. And we're collaborating with laboratories at the Cleveland Clinic and also other universities, academic places like University of Michigan, try to look, for example, on potential biomarkers that can help us select patients enrolled in a clinical trial. As you know, the significant obstacle in improving treatments and finding new treatment options is unselected populations in clinical trials. But at the genomic era, I think we have to become smarter and utilize the science and molecular biology to enrich those patients who have a higher chance to have benefit from particular treatment and spare the others from the potential toxicity of some medications.
Exactly. In this area of targeted therapy, we're finding even some of the more rare tumors or tumors that we didn't realize have certain targets. I'm thinking, for example, in my world of GI oncology, BRCA association with pancreatic cancer or ovarian cancer, as we're developing PARP inhibitors and platinum therapy that we know these tumors respond to. What one or two markers stand out to you in bladder cancer, for example, that you're working on genomic profiling? What markers are you finding that you would have been surprised about a year ago?
I think that's a great question. So just to comment on the PARP inhibitors and the BRCA story, there's some emerging data also in prostate cancer that you have this DNA repair defect. You may have potential efficacy of PARP inhibitors, and there was some data presented in the AACR last month commenting on that potential aspect. Now focusing on urothelial carcinoma, there is very interesting data with FGF receptor alterations, both in terms of mutations and fusions, especially with PAC3 fusions that were described in the TCGA paper in the Nature last year. And actually this is driving potential trial designs in pre-selected patients based on FGF receptor mutations or alterations. Of course, PI3K/AKT/mTOR pathway is another very relevant one. And of course, the receptor tyrosine kinases and downstream signaling is also very relevant. And if you look at the TCGA data, you can have a good picture of what is the potential targets and potential biomarkers, but you have to become smarter in utilizing them in optimal trial designs.
Exactly. I think just a couple of years ago, the journal Science, Dr. Iyer et al. From Memorial Sloan Kettering reported exceptional response to the mTOR pathway of a patient on a clinical trial, and I think it's just the tip of the iceberg. So you're continuing on that path, and it's a very formidable path, and so I wish you the best, and it's great work.
We're scratching the surface, but hopefully we'll get in the bottom of improving patient outcomes.
Absolutely, that's what it's all about. Thank you.
Thank you very much.